right?
Yeah. Well, you have put your year to pretty good use. We're going to talk about that in just a moment. Our visit is presented by Marcus and Mack, voted best law firm, best personal injury lawyer 4 years in a row in the Best of Indiana County contest. You can visit them online at marcusandmack.com. The Comprehensive Breast Center at the Indiana Regional Medical Center, Dr. Billimoria, is a member of the team, and what a team it is. And you, and in the past year, have gone and gotten yourself qualified for genetic counseling now.
Yes, that's right, Todd. I did the genetic cancer risk assessment course through City of Hope in California, and got certified to do that. It was a fantastic course. So anyone who's interested, I can't say enough good things about it. It was mostly online, starting in October all the way through March. And then in March, I did a week of in-person coursework in California, which was great because I got to go there.
There you go.
And I can't say enough good things about it. And, it's been able to expand our genetics program, because prior to me doing this, it was only my colleague, Dr. Dan Clark, who was doing it. And so the wait times to get in for a genetic testing appointment was, 3 months.
Yeah.
So now with me doing it as well, certainly wait times are decreased. And it's such an integral part of cancer care, especially for patients who have certain types of breast cancers, who have a very strong family history. So I was happy to be able to do that. The hospital was very supportive of me going out there. So it's been really good.
This has to do, of course, with the screenings and with helping to find out as early as you possibly can if breast cancer is a risk for somebody, and in many cases helping with that early detection in the very first place.
Yeah, absolutely. There is now a requirement that anyone who comes in for mammography or screening needs to be offered an opportunity to find out what their risk is. Mm-hmm. And so what we do is when women come in for their screening mammogram, they actually answer some questions on a tablet, and it gives them their cancer risk. And based on that, it also determines whether or not they should maybe consider genetic testing. Mm-hmm. And so because of that, the volume of people requiring genetic testing and interested in knowing whether, they need to be more vigilant or not, mm-hmm. is growing.
Is that done by a percentage, a chance?
Yes.
Percentage?
Yeah. So what we go by is a calculation called the Tyrer-Cuzick breast cancer risk calculation. That's the one that we use to determine whether women are considered high risk for breast cancer or not. Mm-hmm. Anyone who has a lifetime risk of 20% or higher up to age 85, 85 is considered high risk. So the high risk screening guidelines are slightly different to what we call the average screening guidelines. So women who are not high risk, where their risk is under 20% up to age 80, they require an annual mammogram and an annual breast exam. Mm-hmm. Women who are high risk, so their risk is 20% or higher, require an annual mammogram as well as a breast MRI, staggered 6 months apart. So if you have your mammogram every January, you have a breast MRI every July, mm-hmm. and then breast exams as well twice a year.
Mm-hmm. Would I be correct to say that this would particularly be helpful in younger women?
You mean the genetic testing?
The genetic testing.
Yes, absolutely. Yeah, especially if there's a strong family history of a genetic mutation. Mm-hmm. Screening for women who have, for example, most people have heard of what we call the BRCA1 or 2, BRCA1 or 2 genes, and these were two of the first genes identified. And if a woman or even a man can carry this mutation. So it's a misnomer to think that only women get this, because that's not true. Men can carry it too, and they can pass it on. And if they carry it, there's a 50% chance they pass it on to their children. Mm-hmm. And so most of the time, if this does run in a family, we recommend that children get tested in about their mid-20s. specifically for this gene, because any kind of screening for this is going to start in your mid-20s. And typically that would start, in your 20s, we typically don't do mammograms because the breast tissue is too dense. So we start with doing breast MRIs. And then once they reach the age of 30, they're alternating the MRIs and mammograms.
Yeah, yeah. And the fascinating thing about the whole science of it all is that the recommendation is age 40.
Correct.
If you're not identified as being high risk.
Yes. So for women who are average risk, so no family history or anything, the recommendation is to start annually at age 40, and that's for the rest of your life until your life expectancy is about, maybe 5 years or so.
Sure.
So just because you turn 75, 80 years old, don't stop getting your mammograms because, the earlier we find it, the easier it is to treat. And for very elderly women, just simply taking out the breast mass with a lumpectomy and maybe just doing some adjuvant, what we call endocrine therapy or anti-hormone treatment can be enough, rather than letting it grow into a large, unmanageable mass. So yeah.
I was going to say the fascinating thing about it is that the way the science advances is really indicating that, ladies, there's really no reason not to be getting your mammogram, or when called for something more extensive like the breast MRI, and it's up to that person to say to themselves, well, I am at risk because it does run in the family, and so start the process.
Absolutely. That's absolutely right, Todd. And one thing I forgot to mention is, average risk starts at age 40, but if you have a family member with breast cancer, your screening actually starts 10 years younger than the youngest family member diagnosed with breast cancer. So this would be like a first-degree family member. So if your mom, for example, had breast cancer at 45, your screening doesn't start at age 40, it starts at age 35.
Yeah.
So just a little nuance there. Yeah.
All right. So we've been talking about early detection and how important it is. Treatment, of course, is the next step, and we certainly want to get into that. But I heard a report this morning about lobular breast cancer being the one cancer that is on the rise most of all in America today. What is lobular breast cancer?
So lobular breast cancer, it's called invasive lobular carcinoma, and it is the second most common form of breast cancer. So the most common form is called invasive ductal carcinoma, and this is where the cancer cells start in the milk duct of the breast, and at some point they break out of that milk duct and they go into the surrounding breast tissue, and that's called invasive ductal carcinoma. That's the most common. Invasive lobular carcinoma starts in the lobules, in the surrounding lobules around those milk ducts. And at some point when it breaks out of that one lobule where it started is when it's called invasive lobular carcinoma. Now, the reason that invasive lobular carcinoma can be tricky is because it is more difficult to detect. Sometimes, back when we used to just do two-dimensional mammography, it was difficult to pick up an invasive lobular carcinoma, especially one that was small. And sometimes you would have a woman coming in for her mammogram and saying, hey, I've got this lump in my breast, and you do a two-dimensional mammogram, and the mammogram doesn't see anything. It looks normal. But, the woman has a lump in her breast, so that obviously requires further investigation. Now, since then, 3D mammography is certainly much better at picking up, small breast cancers, whether they're invasive ductal or lobular carcinomas. They're certainly much better than 2D mammography, but they also still have their limitations. So with invasive lobular carcinoma, it's not uncommon where when we find it either in mammography or ultrasound, that we usually land up getting a breast MRI to really see the extent of disease, because sometimes the mammogram or the ultrasound may only show a small mass, but then you get the MRI and it really shows that it's a lot bigger than what we're seeing.
Lobular is sneakier then.
It is sneakier, absolutely. So that's why I always say, if a woman has a lump in her breast and she got some imaging and the imaging was negative, don't let it go.
Yeah.
Further investigation needs to be made.
Absolutely. All right. So we've been talking about detection. We need to talk a little bit about treatment this morning as well, because there are all kinds of different treatment protocols. Those change just as much as the detection protocols, don't they?
They do. They do. From my perspective, I do surgery. So from a surgery perspective, not too much has changed. Where most of the changes have happened are in the adjuvant or neoadjuvant chemotherapy, and then also the radiation that patients are receiving. So that's where most of the advances have been made. In terms of surgery, that hasn't changed too much. Basically, if you have a small breast cancer, you do have the option of what we call breast conservation, where we're not removing the whole breast. We're just removing a lump that contains that cancer. And then you'll require some treatment afterwards, like radiation to the breast to help decrease the risk of the cancer coming back. And then the other option, of course, is a mastectomy, which is a complete removal of the breast.
Yeah.
So from a surgical perspective, not too much has changed, but it's all the adjunctive treatments that have really soared.
You and the entire IRMC Breast Center team are going to be at the Light the Way Breast Cancer Awareness Candle event coming up on October 20th at the Philly Street Candle Bar.
Yes, we are, and that's in the that's on the 20th of October. I believe it's at 5 o'clock. 6 o'clock. 6 o'clock. Excuse me. And yeah, we're looking forward to it. So if you haven't signed up, please do. We're all there. We're there to answer questions, and so please come.
Going to make a candle?
Yeah, I think so.
Yeah. Have you done it before?
I have. I
understand it's a ton of fun.
Oh, it is. It is. And they have so many different fragrances in there, and you try to mix. And then you kind of get an appreciation of, it's kind of hard to make, fragrances and things like that, knowing which ones to mix and things. It's a lot of fun.
Yeah. But folks will come out for this event. And again, there is a QR code at irmc.org/2025. You'll find the Light the Way Breast Cancer event. Just scan the QR code or call 357-7188. You want to get in on this, but it will be a fun event. But it really is an important event because it gives people in a different setting, not such a clinical setting, an opportunity to ask questions.
Yeah, absolutely. It's very informal. No question is a silly question. Even for people who are hesitant to get mammograms, sometimes people say, isn't that a lot of radiation? And really it's not. Getting your yearly mammogram, the radiation is negligible to potentially, having a CT scan.
Sure.
Even. So I can't encourage you enough to come out and meet our team. Like I say, we're happy to answer any question. No question is a silly question. If you have it, someone else has it as well. And we're happy to do it. We're happy to be there. So
that's a good point. 357-7188 if you want to get signed up for this event. Monday, October 20th, 6 p.m., the Philly Street Candle Bar in downtown Indiana at 8th and Philadelphia Streets. She did this interview despite being heckled from outside the window by her husband, who happened to be walking by.
Yes.
Tell you what, she's a trooper, huh? Dr. Nazneen Billimoria, thank you so much.
Thank you so much.
It is the voice of Indiana County, WCCS, 101.1 FM, AM 1160, WCCSradio.com.